In this video, we're going to discuss some of the most common muscles pertaining to the cervical spine. And for each of these muscles, we're going to go over the origin, insertion, innervation, and action. And then we're also going to bring in some clinical significance. Now, the clinical significance is heavily dictated from a movement impairment perspective, and it doesn't always correlate with pain. So we're going to talk about muscles as being either overactive or hypertonic or underactive or hypotonic. And muscles that work over and over again, or they can create tension or stress or a perceived sense of something overworking, and that can contribute to someone's pain. Now we know it's more complex than that, but that's our general overview of how we're going to be discussing these for this particular lecture. First of all, the upper trapezius. It is one of the kind of most commonly overused or dominant muscles for people who are experiencing shoulder or neck pain. This muscle comes from the external occipital protuberance, so you can see that it goes all the way up to the base of the head and then runs down to the C7 spinous process, the ligamentum nuchae, and then also the superior nuchal line. So that's all of the origin there. Insertion, it will run out to the lateral third of the clavicle. Innervation is from the spinal accessory nerve, and then also spinal nerve C3 to C4. Action, it is going to elevate, retract, and upwardly rotate the scapula, and then it also has some cervical contribution. But my main focus in this lecture here is talking about the scapula. So it elevates or lifts up the scapula, and then upwardly rotates, but also provides some retraction. That upward rotation piece is key because many times I see people in the gym or people who are having shoulder pain that end up doing a lot of shrug type movements down here. But if they're trying to make these muscles stronger, really we need to work the muscles overhead. We need to work them in that upwardly rotated and elevated position. So I say the upper trap, it can be short on some people, but more importantly, we need to strengthen that muscle if it's commonly trying to be used down here, or if other muscles are constantly pulling the shoulder into downward, shoulder and cervical spine for that matter, then into a downwardly rotated position. So when training, a clinical tip, if you're training the upper trap, bring them in 90 degrees and then work on elevating the shoulder. That's going to isolate the upper trap muscle while turning off muscles like the levator. A common exercise I give people is arms all the way overhead and maybe potentially on the wall with a foam roller pressing against the pinky edge of the hand, and then working on lifting and getting that scapular elevation or shrug. Next, levator scapulae. This comes from the transverse processes of C1 to C4. So this connects onto the cervical spine and runs down onto the superior angle of the scapula. For this reason, it can impact the cervical spine and it can impact the scapula and shoulder. Coming from spinal nerve C3 to C4, and then also C5 with the dorsal scapular nerve. And that's the one that most people have probably heard in PT school. This one has similar function to the upper trap, but is slightly different as we discussed. So they both are elevators elevators of the scapula, but then now the levator is a downward rotator as well. So the upper trap helps with the upward rotation. The levator downwardly rotates. It also has some cervical contribution, so it helps with cervical rotation and side bending. And then if you look at the clinical significance, the levator scap often becomes a dominant scapular elevator, but then because of that, it's also going to pull them into downward rotation. And someone who's chronically stuck in downward rotation is going to come in with shoulder impingement or maybe potentially a degenerative rotator cuff tear, because as they're lifting their arm up, that motion isn't coming from the upward rotation. The shoulder blade is getting stuck down, and it's going to lead to some impingement type symptoms. That is something that you'll commonly see. And then also you will see people who have either a hypomobility in the cervical spine or some cervical type of irritation because the levator will be pulling from the scapula to the cervical spine. Again, this is a very biomechanical or muscular way to approach how someone may be having symptoms. Combine this with the complexity of pain to really bring in the full picture. Anterior, middle, and posterior scalenes. The origin of these is all over the place from C2 to C7 transverse processes. And you can see that in the picture where it runs from numerous transverse processes. Anterior and middle attach onto the first rib. The posterior attaches onto the second rib. And these muscles assist with breathing. They assist with cervical side bending. And they also elevate ribs 1 and 2. So you can imagine if the neck is fixed and they're pulling up, they're going to raise ribs 1 and 2 up. Clinical significance, these muscles often become overactive with chest dominant breathers. So someone who is not using their diaphragm and only using up here, you'll see them breathing a lot through their pecs and through their upper chest. And since we breathe about 20,000 times a day, you could think about those scalene muscles being overused 20,000 times a day relatively. You may also see people who have some first and second rib hypomobility that is contributing to rib dysfunction, thoracic outlet syndrome, etc. These muscles are kind of near and dear to me specifically because I had venous thoracic outlet syndrome on my right side. And they actually took out my first rib. So from front to back, they removed the first rib. Because of that, the anterior middle scalenes came with it. So I no longer have an anterior middle scalene. If you look at my posture, my right shoulder here is a little bit lower because the scalene muscles are no longer helping it hold up. But then also how the first rib articulates with the collarbone, it no longer has that support here. So a combination of the muscles, but then also the bony anatomy has been altered. And I feel that with cervical side bending and rotation. And that's how it really showed me that how these muscles play a role in cervical mechanics. The deep neck flexors. So this is our rectus capitis anterior, rectus capitis lateralis, longus capitis, and longus coli. In the picture, that is the longus coli. So these run, the longus coli specifically is with the origin, insertion, innervation, and action here. Goes from C3 to C5 transverse processes and the anterior bodies of C5 to T3. So this muscle goes pretty far down into the upper thoracic spine. Innervation, it goes to the anterior arch of the atlas, the anterior tubercles of C5 to C6 transverse processes, and then also the anterior bodies of C2 to C4. So it runs upward or superior caudal, cranial, I'm sorry. Innervation, C2 to C6 ventral rami, and then this acts on the cervical spine. So this allows all of these muscles work on deep neck flexion, so cervical flexion, and then unilaterally they assist in cervical side bending. So if I'm thinking about my left longus coli or my left deep neck flexors, they help with the side bending of this region. As you can see in the clinical significance, these muscles are deep cervical spine stabilizers. They act as a sling to help the vertebral bodies move, and they're often found to be weak or inhibited because of a more dominant sternocleidomastoid or more dominant scalene muscles. Clinically, many people perform the deep neck flexor endurance test in supine, and that's a very common test for people who have motor control deficits or movement impairment deficits based on the treatment-based classification for individuals with neck pain. Think about these muscles needing more strength. Generally, the way to achieve that is by performing a chin tuck and then doing other challenging movements. And they need more strengthening because of the next muscle we're going to talk about is usually overworking or too dominant. So the sternocleidomastoid, or SCM, it runs from the nubrium and the medial clavicle, as you can see on the bottom edge where it says origin here, and then runs cranially towards the mastoid process and superior nuchal line. Due to that innervation, or due to that origin insertion, you'll often see people who have more of a forward head posture that puts this muscle in a position to work more than it should. The innervation here is the spinal accessory nerve and C2 to C3 ventral rami. And if this muscle is working unilaterally, it performs contralateral cervical rotation, and then ipsilateral side bending. I often think about, if you study the Kendall manual muscle test book, there's the picture of the gentleman in that book where they're doing the strength test of unilateral side bend and then rotation, and it just exposes that muscle here. That is the action unilaterally. Bilaterally, it assists in cervical flexion. So if this muscle is working hard, then the deep neck flexors maybe aren't kicking in quite as much, and that can contribute to neck pain and shoulder pain. Clinical significance there, the SCM often becomes a dominant muscle for cervical flexion. This can lead to abnormal cervical mechanics, and then also because of the angulation and close proximity to the TMJ, it can lead to temporal mandibular dysfunction as well. And then finally, the suboccipital triangle. I'm going to talk about this more generally. These are the muscles that are on the base of your neck. The medial border, so if you think about the spinous processes, right along the medial border, you're going to have the rectus capitis posterior major, the superior and lateral border. So if you think about the green muscle here on the picture, obliquus capitis superior, and then the inferior border is going to be the obliquus capitis inferior. That's the muscle shown in red. These three muscles, they are closely connected to our proprioceptive input and then fine motor adjustments. And when I'm teaching in person, I often have people put their thumbs on the back of those muscles and then just look left and right, and you can often feel some muscle activity here, because those fine motor adjustments, as our eyes are working and they're getting a sense of our environment, these are kicking in to give us a better idea of where our head and neck is in relation to space. Additionally, the suboccipital muscles, there are different structures that pass right through there, and specifically the suboccipital nerve runs right through the muscles. So individuals who have headaches, this nerve can often get kind of entrapped or impinged in there as they run up onto the backside of the head. So that referral pattern right into the eye, that can be due to these muscles being overworked or overused, or the C0 to C2 region is not moving properly. And as you can see, each one of these muscles runs from either C1 to C2 or C0 to C1. So it's closely connected to the upper cervical spine, and then that's closely connected to individuals with headaches. So a whole bunch of things to look out for. As you review all of these muscles, again, we're talking about them from a movement impairment perspective primarily, and then we'll cluster what you find with how someone's moving, then with a greater picture of what their pain is like.